Thank you for joining our webinar. My name is Katy Ajer, and I am the Program Director of Health and Sustainable Development with the Evangelical Lutheran Church in America, a CCIH member. Currently in this role, I work with stewarding grants for various development projects in countries around the world and communities around the world through local community churches. My background is in public health, specifically maternal and child health. And before my current job, I worked primarily in direct care services in the United States and in other countries. And part of that being helping to connect those with HIV with the appropriate services or testing for healthcare. So we're going to go ahead and get started today. For those of you who don't know, Christian Connections for International Health, otherwise known as CCIH, is an international network of approximately 150 Christian organizations, about 50% with headquarters in the United States and 50% in other countries. CCIH's mission is to promote health and wholeness from a Christian perspective, and we are glad you are joining us for this webinar on HIV and AIDS and thinking about what people of faith can and have done to address the epidemic. I will introduce each speaker before they share, and we will hold all questions until the end. Please use the chat box in the upper right-hand corner of your screen to ask questions. You must be signed in to Google in order to post a question on the YouTube chat box. Our first speaker is Dr. David Barstow. David has a PhD in computer science, and after a 40-year career that included teaching, industrial research, entrepreneurship, and consulting, he felt called to change directions to focus on the AIDS epidemic. For the last 10 years, he has worked with local pastors in Southern Africa to help them reduce the stigma associated with HIV and AIDS. He has also been involved in global initiatives related to faith and AIDS, working with the World Council of Churches and UNAIDS. He is currently producing a documentary film about the future of the AIDS epidemic entitled How We Lost the War Against AIDS. David, I'll turn it over to you.
First, thank you to CCIH for hosting this webinar and to Kathy for organizing it. The future of the AIDS epidemic is a very important topic for many millions of people. Also, let me apologize in advance if I sometimes seem to be focused on the American response to the AIDS epidemic. Frankly, it is on my mind every day. The U.S. has provided strong leadership in the global response. I hope and pray that we will continue that leadership. So what is the future of the AIDS epidemic? The year 2030 will mark the first half century of AIDS. If epidemiologists in 2030 look at the history of the epidemic, what will they see? Certainly, one possibility is that AIDS will effectively be over. New HIV infections, shown in green on this chart, and AIDS-related deaths, shown in red, will continue declining from their peaks in the 1990s and 2000s. In 2030, they will not be all the way down to zero, but they will be at manageable levels. HIV and AIDS will no longer be significant threats to public health. But unfortunately, there is another possibility. AIDS may come roaring back in the 2020s. Despite all the progress we have seen in the 2010s, the rates of new HIV infections may go back up, followed by an increase in AIDS-related deaths. The epidemic might even be as bad in 2030 as it was in the 90s and 2000s. We can even imagine a filmmaker in 2030 producing a very sad documentary about the history of the epidemic, a film that might be titled How We Lost the War Against AIDS. In fact, there is already a trailer for the film, which you can view online at the URL that you see there. I'd encourage you to take a look. Obviously, the theme is quite depressing, but hopefully it is also motivating. Now, of course, it is only 2018. It's not 2030. No one knows for sure what the future of the AIDS epidemic will be. We all hope that the first future I described is what comes to pass. But unfortunately, tragically, the second future is a real possibility. Why might that be? Why might we fail to end AIDS? First, do we lack the knowledge, the scientific and medical knowledge to end AIDS? No. We have the knowledge that we need. From a scientific and medical perspective, we know what to do to end AIDS. Second, would it cost too much? No, the economic return on ending AIDS would be huge. Ending AIDS would cost remarkably little. No, if the AIDS crisis isn't over in 2030, it will be because of two other reasons. It will be because of complacency, or perhaps apathy, about progress in fighting against AIDS. And it will be because the moral and social issues around HIV and AIDS are too complex. Complacency and apathy, moral and social complexity. Those are the things that could lead to an extra 10 or 20 million people dying between now and 2030. And they both are areas where Christians and people of all faiths have an important role to play. So let's expand on these a little bit. First, complacency. Believing that the AIDS crisis is over, that we solved it all back 5 or 10 years ago. I haven't seen any studies or surveys, but I'll bet that if you were to ask most Americans about the AIDS epidemic, and probably many people from other countries, they would have this sense of complacency. A vague feeling that there may still be some people who get AIDS, but certainly if the numbers are going down, there's only a question of time before we get to zero. Unfortunately, that vague feeling is wrong. There is no reason to be complacent, and there are many reasons not to be complacent. Now, I'll admit, I fear it's not just complacency, but also to some degree apathy, not caring whether or not the AIDS crisis is over. And frankly, not caring is a lot more dangerous than not knowing. As I'm sure many of you know, things in the US have been a little chaotic lately, and it's hard to tell who cares about what. But I can say that I believe that we Christians, as well as people of other faiths, have an obligation, moral responsibility to care about the AIDS epidemic and the people that it affects. That we are not allowed to have a don't care, apathetic attitude. So I certainly hope that complacency is more common than apathy. Complacency can be cured with knowledge. Apathy is a lot harder to cure. The other reason we might not end AIDS is that there are some very complex moral and social issues that surround the disease. HIV is the virus that leads to AIDS. HIV transmission is often associated with behavior that is seen by many people as bad, like certain kinds of sexual activity or the use of injection drugs. This association with perceived badness often results in judgmental attitudes, believing that somehow people who have HIV deserve it, that they behaved irresponsibly, and now they're paying the price. In addition to moral complexity, there is also social complexity. Different countries and different cultures may have different social dynamics, but the social dynamics are always complicated. For example, poverty sometimes leads young African girls to hook up with so-called sugar daddies, older men who provide them with food and financial support. But after a while, usually after they are infected with HIV, the young girls are dumped. Then, when they try to have normal relationships with men their own age, the disease spreads and eventually goes through another cycle of older men and young girls. As another example, the part of the world with the highest rate of increase in new HIV infections is actually not Africa. It is Eastern Europe and Central Asia. After the collapse of the Soviet Union, there was a significant increase in use of injection drugs, which can lead to an increase in HIV infections. We have seen similar things in the US associated with the opioid epidemic. The bottom line is that the AIDS epidemic is much more complex than other diseases. Compare HIV with malaria. It is only transmitted by little mosquitoes, and no one thinks you're bad if you get malaria. In contrast, HIV has many modes of transmission with many dimensions involving social and moral issues that are very hard to deal with. And that is exactly why we need people of faith to address these issues. It is our faith that compels us to tackle hard issues that are at the center of the human condition, and to address these issues with all possible compassion, love, and acceptance and humility and dignity and respect toward all of God's children. The idea that HIV and AIDS might come roaring back is pretty frightening, but it's not a new idea. A few years ago, in 2014, a detailed analysis of the global epidemic was published by the Lancet Medical Journal and by UNAIDS. The analysis included two projections about the AIDS epidemic through the year 2030. The projections varied depending on the size of the global response to AIDS. In numeric terms, the world invests about $19 billion every year in fighting HIV and AIDS in low and middle income countries. About half of this comes from donor countries like the US, and about half from domestic sources in the countries that have high prevalence rates. If the world would increase its investment by about a third, AIDS would gradually be brought under control, disappearing as a public health threat by the year 2030. But if we continue at the constant rate, AIDS would start coming back. The number of new infections would start to rise again. There wouldn't be enough medication. Prevention techniques wouldn't have a broad enough reach, and there would be a snowball effect. In the UN AIDS model, the critical time period for making a difference was from 2015 to 2020. Now, you may be thinking to yourself, it's early in 2018. We're right in the middle of the critical window. How are we doing? Well, last summer, the annual conference of the International AIDS Society was held in Paris. And there was a kind of report card on our progress. Bottom line, numerically, we actually are making great progress. For example, more than 2/3 of the people living with HIV know their status, and more than 40% are on treatment and virally suppressed, meaning they are no longer infectious. These numbers are global averages. There are also several African countries that are making progress much faster. So that's all really very good news. But numerically, there was one bad data point. The number of new infections is not going down. It's staying pretty steady at about 1.8 million per year. In the words of Michel Sidibe, the head of UN AIDS, the progress is great, but it is very fragile. His biggest worry is resources, that complacency will lead countries to lower their investment. We have already seen signs of that happening. Some countries have seemed less willing to put in the investment we need. President Trump's original proposed budget for fiscal year 2018 included a cut of about $1 billion in funding for PEPFAR, the President's emergency plan for AIDS relief. PEPFAR, together with contributions to the Global Fund, are the primary mechanisms by which the United States contributes to global AIDS relief. Fortunately, there has long been strong bipartisan support for PEPFAR and the Global Fund, and there is some hope that we will end up flat with no cut. In the current political climate, my friends in Washington would consider that a victory. But it would also be a defeat. For minimal funding, we should be providing what is needed to ensure that we end AIDS. There were two other risks highlighted at the Paris conference. One is the problem of stigma, which is the word often used for those judgmental attitudes I mentioned earlier. Stigma leads many people to avoid testing and treatment. They're worried about what their neighbors will say. And the result is that they die faster and the disease spreads faster. Stigma is especially bad for marginalized populations, like men who have sex with men, sex workers, injection drug users. It also applies to all people who have HIV, regardless of how they became infected. Sometimes it's a little hard for us in the well-to-do parts of the world to understand the dramatic effect that stigma can have. Why would somebody knowingly not get tested for HIV or not get treatment for HIV? But then think about more familiar diseases like mental illness or alcohol addiction, and think about our reluctance to talk about them or to seek treatment. We are reluctant to talk about mental illness or alcohol addiction because we are worried about what the neighbors will say. Stigma is the reason for our reluctance, just as it is the reason that many people are reluctant to seek help with HIV. The other risk identified at the Paris conference was a rapidly growing youth population, especially in countries that have high prevalence rates. This is where we have the biggest worry about new infections. What is going to happen to those young people? They are in the risky years. The social dynamics are complicated. They get mixed and incomplete messages about HIV prevention. The result could be a rapid increase in new HIV infections in the generation we keep hoping will be AIDS-free. So the AIDS crisis is not over. In fact, right now we are at a tipping point. It could go one way or the other. It could go toward the first future I described, toward ending AIDS as a public health threat by 2030, or it could go toward the second future I described that is depicted in the trailer, a future that is catastrophic in human terms. What would it take to avoid the second future, to get us on the path toward ending AIDS? There are basically 5 things that we need to do. First, provide the resources needed to end AIDS. Instead of being happy that we are staying steady, let's go ahead and fully fund the plan laid out by UN AIDS. Invest in prevention, invest in treatment, invest in science. Make sure we have enough medication. Keep making progress on a vaccine. In the grand scheme of things, the extra investment would be pretty cheap. And speaking as American, I would be thrilled if we provided the global leadership that would make the increased investment possible. Second, ensure universal access to HIV prevention and treatment services. Currently, almost half of the people living with HIV are not on treatment. Reaching them will require getting into areas around the world that may be difficult to reach. Faith communities and organizations have long been at the forefront in providing HIV services. Currently, more than a third of all HIV services are provided by faith-based organizations. It is vital that we continue to be at this forefront. Now, let me emphasize two additional points about universal access. First, it's not just testing and treatment. It's also about prevention. We need not only testing kits and medication, but also education and other prevention programs. Second, it's not just geographical reach. It's also social reach. We need to get to the people who have been marginalized by society. Universal access requires delivering HIV services with dignity and respect, without stigma or discrimination or fear of criminal prosecution. In fact, ensuring universal access will also require services specifically targeted for marginalized and at-risk populations. We will have to overcome our judgmental attitudes in order to achieve universal access. This is an area where people of faith have a very important role to play, and an area that we sometimes find problematic. We need to bring to bear all of the humility and compassion that we can find. Third, align public health policies with scientific evidence. Many people have difficulty dealing with the fact that HIV and AIDS are associated with socially complex contexts. We are afraid that if we talk about sex, it will encourage young people to have sex more often. We are afraid that if we offer needle exchange programs, it will lead to widespread drug use. We are afraid that if we decriminalize same-sex behavior, it will make people become gay. So we often implement programs and policies based on these fears. Yet the scientific evidence doesn't support the fears, and ignoring the evidence just makes the epidemic worse. This is another area that can sometimes be problematic for people of faith. It may be helpful to remember something that Reverend Gideon Biamagisha said more than a decade ago. He was the first African religious leader to be open about his HIV-positive status. He pointed out that we can distinguish between two different dimensions of human behavior, namely, behavior that is according to God's will, as compared to behavior that is safe with respect to HIV transmission. We may have very long arguments about God's will for our behavior, but discussions about safe behavior are based on scientific evidence. Fourth, strengthen community-based services. During the course of the 35 years of the AIDS epidemic, we have learned that community-based services can be very efficient and effective at prevention, testing, and treatment. There was a CCIH webinar on community-based healthcare just last month. This is an area where faith communities have long been at the forefront and must continue to be. And faith communities are also the best leverage point we have for fighting stigma and for educating young people about HIV and AIDS. Finally, strengthen advocacy and awareness programs. We have to re-raise awareness, both in wealthy countries like the US and in poorer countries where the HIV burden is high. In my mind, this is a role that is especially important for global religious leaders. Right now is a critical moment in the AIDS crisis, and globally recognized religious leaders have the moral authority to demand that we collectively commit to ending the AIDS epidemic. They can serve as our global conscience. So globally, collectively, that's what we need to do. What about us as individuals? First, raise awareness. Talk with your friends. Ask them if they know that 1 million people die every year around the world from AIDS-related diseases. Ask them if it's worth a little more effort to save 10 or 20 million people from dying needlessly in the next decade. Second, take political action. For the Americans who are listening, advocate for a renewal of American global leadership through things like PEPFAR and the Global Fund. Tell your representatives to not simply renew, but to increase the budget. For those in other countries, advocate for the right political steps in your context, perhaps related to decriminalization, perhaps related to discrimination, perhaps for increased domestic funding. Third, promote HIV education for young people. Make sure they know all of the prevention choices, even if you feel a little uncomfortable talking about the choices. I remember a pastor in Zambia speaking with a pained look on his face. I really don't want to talk about condoms, but I know that if I don't, young people will die. Fourth, mobilize your faith community to become active in the AIDS response. The best things to do will be different for different faith communities in different contexts. For some, it might be advocacy and activism. For some, it might be providing services and counseling. For some, it might simply be prayer. So start by talking and then do something. And this is a topic that our next speaker will be talking about from her experience in Kenya. So thank you for your time. I believe there will be more time later for any questions you might have.
Thank you for sharing that, David. Our second speaker is Nkatha Njeru. Nkatha is an experienced public health specialist who has worked with the faith sector in Kenya for the last 15 years. He has worked at health facilities supporting health system strengthening and grant management for faith-based health facilities in Kenya. She is the coordinator of the Africa Christian Health Association platform, ACHAP, and in the past year, Nkatha has been involved in work with religious leaders in Kenya, developing their capacity as champions for HIV care and treatment, as well as developing an HIV counseling guide for religious leaders. Nkatha, I'll turn it over to you.
Thanks, Katie. Thank you, everyone, for listening. Speaking to you from a sunny Nairobi evening. I work for the Africa Christian Health Association platform. We're a network that works with Christian health associations and church health networks from around sub-Saharan Africa. We were established in the year 2007. Our membership is in more than 30 countries with over 40 members. Like I said, we are based in Nairobi. We come together to network and communicate as Christian health associations. We also work together as members of Christian health associations to advocate jointly for matters on health development. We also support capacity development of our members of ACHAP in the different countries. And we also try to establish and maintain partnerships with other institutions and organizations of similar agenda. In relation to what our topic is today, thinking about what the role of religious leaders is, Africa Christian Health Association platform is a Christian health organization. And therefore, Christian health networks and organizations have their roots in various churches. And one of the things that we have been thinking about is what is different about us. What is different about healthcare provided by a faith-based organization vis-a-vis any other private or public organization? And we know for sure that our roots in the church is one of those great things that is different about us. And therefore, we are starting to think about then, how can we provide healthcare in a way that is different and that has maybe different results from the rest. So we have gone back to working with our religious leaders. We have worked for many years with other kinds of champions in communities who include the community health volunteers. So we think that working with religious leaders as champions for health is another way that can enhance health. And why this? Because one, religious leaders have a captive audience weekly. Services are held on Fridays, Saturdays, Sundays, depending on when each congregation congregates. People trust their religious leaders. They provide continuity and sustainability, unlike many other modes of reaching out to communities, such as community health volunteers will sometimes leave their communities, they move out, they get other jobs, or they move to the village if they were living in the city. But the church that exists in a community is there for forever, usually. And people go to their religious leaders usually as their first point of information, of resource. And as such, they really are an influence, so they are gatekeepers. The word of the pastor, the reverend, the sheikh, the imam is really gospel to their community. With this in mind, therefore, we have various things that we are doing, or when I say we, I mean we at the level of the Secretariat as ACHAP, as well as various members of ACHAP in different countries. We are going back and building the capacity of religious leaders on health issues, be it HIV, be it family planning, be it issues to do with sexual, gender-based violence. We are building their capacity. We are also developing materials to support faith leaders. We are engaging with policymakers at those levels to help them understand that faith leaders actually are a resource that can be tapped. We are also supporting the implementation of projects through the churches. In this regard, therefore, in terms of capacity building, what is it that we are doing? We actually run workshops to train the religious leaders in the communities. And beyond running those workshops, we are linking our religious leaders with our member health facilities. So for a long time, churches and health facilities that are church-based have worked at silos, that the religious leader or the pastor works from the church, and the health worker in the health center works in their space. But we are starting to want to link them and to make them work together as partners, because anyway, they one is a mother and one is a child, and vice versa. So what are we learning from this capacity building? One of the first things is that it is important to keep the capacity building or the information we give simple and basic. Just last year, I have been doing trainings in HIV, and very interesting to note is that our religious leaders that we trained, I was doing a training in Kenya, and the religious leaders are just as uninformed as any member of their community in which they are in. So if it is talking about HIV and AIDS, it's from what is HIV, how is it spread, how can you get tested, what happens when you have HIV, what happens when you have AIDS. So keeping it simple and basic, and not assuming that since they are religious leaders, they know it. And like I've just said, then their concerns and questions are just similar to what their communities would be asking. And we also have realized that it is important to just provide a safe space. Don't judge them that because they are religious leaders, they do not have the same concerns. I remember that one of those trainings, we brought in counselors to do HIV testing. And the same fear as any other human being would have on, should I go for testing, is the same fear that a religious leader has, but we explain the importance of getting tested so that they talk to their communities from a point of experience. So we provide them with a safe space to ask any question, just like anybody else that would be talking to. We also, it also helps, therefore, to have one of them that is living with HIV come into those workshops and talk to them from their own experience. Then it is not a case of it is a case of people, even we religious leaders are also experiencing the same things that our community members are experiencing. I have talked about getting tested and the fact that it's important to provide them with a safe space, bring in somebody who will make them feel comfortable for them to get tested. Then beyond just training them, we would like to be able to have to monitor what is actually happening after this. So whatever tools we create, we ensure that those tools are simple, that they're not going to make their work too hard, because I mean the religious leaders have their main objective with their congregation. So when we bring in the health as part of the things they need to do, and we want to monitor, we have to keep those tools very basic. And then we also try to arrange meetings at convenient dates and times with regard to their other calling. And we also prepare these health facilities in their communities. Because, for example, if on a Sunday or on a Saturday, someone is preached on getting tested, we have realized that the kind of mobilization that happens means that therefore we get a lot of people who want to go for actual testing in the health facility. Therefore, the health facility must be ready to receive these people. Then, in terms of our data, we have realized that there's much more male engagement. A lot of men come out for testing, come out to talk about their status, come out to support the women when we have the religious leaders talking to them. And we also ensure to include women and youth leaders in congregations. So we are not only targeting the pastor or the reverend or the sheikh or the imam. We also want to, there are other kinds of leaders in the church that we work with. And we are also very careful not to upset existing systems of the government or otherwise. So if community health volunteers have been working in that community, we try to work together with them. The next slide, this slide is showing some of the results we've had from some of the work. This is data that we got from Kenya. The Christian Health Association of Kenya was working on a program with the IMA World Health on a USAID-funded project. And between August of 2016 and September of 2017, the number of referrals by religious leaders, as you see there, was the highest in relation to what came out of referrals by community health workers and youth leaders. So really, this just goes on to affirm what we are talking about in terms of religious leaders being a voice that can change the tide. The next slide is just basically the same, talking about religious leaders. Beyond just sending people for testing, we also had in this project support services like psychosocial support, nutrition services, treatment adherence. So our religious leaders were trained in how to provide psychosocial support, refer people for nutrition services, support those that are on treatment. And the largest number of support services were provided by the religious leaders. Usually people go to the religious leaders anyway when they have a problem. So to us that was not surprising, but we were pleasantly surprised that the same thing is happening even in health. Beyond that, then we also do other things beyond capacity building. We do development of materials. So beyond building the capacity of the religious leaders, we also want to make sure that then they have the tools that will help them to reach their communities. So we have various Christian health associations with support from various technical agents working on sermon guides and counseling guides. Those are two tools that we have developed. Sermon guides are tools that are referring to, and I'm talking about the Quran and the Bible, because one of the things we've realized is that it's not helpful for us to just work with just the Christians and leave out the Muslims if they exist in a community. So we look for ways of integrating. So sermon guides are basically looking through the Bible. And for example, if it's on HIV and AIDS, looking at what would provide guidance if a pastor was giving a sermon on testing, on caring for children, and we pick out verses from the Bible and help them to use them to pass messages, health messages using them. We've also developed a counseling guide because we realized that beyond preaching on the pulpit, people are now going to their religious leaders and telling them, Pastor, you say that we should get tested, that it is important that people perish. For example, the verse on people perish for lack of knowledge, and people go and get tested. And they come back to their pastor or to their religious leader, and they're sharing about their status I have not disclosed to my husband. I am afraid that I would like for my children to be tested, but I am afraid. And the religious leaders didn't know what to do. So we've put together a counseling guide to help, which should be up on our website in the next few weeks. And the counseling guide is helpful in providing guidance to the religious leaders in knowing how to go about counseling. And basically, I have just outlined the process that we use. So we really develop a framework for the content, be it for a guide or for a sermon guide or for the counseling guide. And when we are working on the theological reflections in the sermon guides, we ensure to have technical experts, academicians, some of the end users and religious leaders that we work with, all in the same room, Muslims and Christians, come up with the verses from the Bible, from the Quran, that we will refer to in the guide. And then we pretest and do corrections depending on what we get. And of course, after that, we train the religious leaders on how to apply it. When you stand at the pulpit there and this is the sermon for the day, how do you go about it? What are the lessons that we've learned from this? Engaging all stakeholders. You must know who your stakeholders are. Otherwise, you come up with a guide and it's a sermon guide for Christians and you only called the Catholics and the Pentecostals and you left out the SDA and they're in that community, it will not be well received. It's also important to be sensitive of the different interpretations of the messages in the Bible. You also need to ensure continuous supervision. And like I said, religious leaders are really, they have a great role in the community, in being counselors in that community. So beyond development of materials, the next slide is showing is really an example of what the guide is. That link there takes you to the sermon guides specifically for children and HIV. And that slide provides you with what the process was, like I have talked about. The slide after that is giving an example, is really illustrative of what is in the guide. For example, we have there in the Christian sermon guides, the truth shall set you free. Get tested for HIV regularly so that you know your current status. And we have Hosea 4:6. My people perish because of the lack of knowledge. And in the guide, we provide guidance on how to take that message and refer to testing using the message in Hosea 4:6. And in the Islamic guide, the same thing, using that message. Beyond that, I will talk about engagement with policymakers. So policymakers, especially at government level, so we have worked with policymakers to help them recognize the place of religious leaders in health, to help institutionalize the systems, including faith-based, the faith-based as a partner. For example, in Kenya, the National AIDS Control Council now has tools. Part of the community tools are tools for the faith-based, the churches, that the community groups, the faith-based community groups, to use to report to the national systems on what they are doing. Because really religious leaders have respect from political leaders, and their word is listened to. And I just talked about the Christian Health Association of Kenya has been part of the National AIDS Control Council Faith Sector Working Group. And if you go on that website, you will see some of the materials that have been designed and the messaging of which we have been part of, including in the development of policies. And therefore, lastly then, what happens as a result of this engagement? We have seen greater demand for creation for testing. Like you will see the slide that I had put up showing how many of the referrals have come from religious leaders doing the mobilization, as well as referral for services, because when we train them, just like you have in the curriculum for training community health workers, what do you look out for? Who are the people that you might want to talk to? Somebody who has lost a husband or a wife and a child that is sickly. So they know, the religious leaders know who to talk to about going for testing, about going for treatment. So people have come up for care and treatment because of them, and they have remained on treatment because now they are having support from even the church. The church is not judging them. As well, adherence counseling is getting better because we have religious leaders as well emphasizing to their members, you need to take your drugs like you should. Spiritual counseling, which is also a very important aspect of counseling because these people are in the church. And as well, psychosocial support. I will again give an example of Kenya. In Kenya now, it's possible to go and get in the pharmacy a kit and test yourself for HIV. So what happens after I test HIV positive? Who do I turn to? I'm not in a counseling room. I have all the feelings running through me. Who do I talk to? If I know that my pastor is ready and willing and accepts me as HIV positive, then I can go to my pastor and talk to them. Prevention campaigns, they can run prevention campaigns with the youth. They're able to run prevention campaigns with different groups in the churches. And as well, I think it's enriching couple counseling because before people were aware, we had cases speaking with, for example, in Erela in Kenya, they had issues with pastors want to see the results of couples. And when they test HIV positive, they're not ready to marry them. But when we are training them, then they know what to do with a couple that is HIV positive, even if they're discordant, because they have some counseling skills as well. So as far as we are concerned as ACHAP, we think that it's really a very important thing. That last photo there is the launch of the religious guides that we had sometime in June last year. Thank you very much for listening. I hope that this is going to lead us to do much more with our religious leaders. Thank you.
Thank you, Nkatha, and thanks to you both, Nkatha and David. So we do have some questions. We're going to go ahead and I'll throw them out to you both, and then yeah, we have about 10 minutes, 15 minutes for that. So first question is coming from Gloria Ekpo from World Vision. She says, stigma is still a significant barrier to access to HIV services. What suggestions do you have for the faith communities to reduce stigma and improve access to services? And Nkatha, maybe you can take that first, and then David can follow up with it. Yeah, if he has anything to add.
Sure. I agree that stigma has been a big problem, and I will talk from some of the work that we've been doing with religious leaders. I think when we've worked with our religious leaders in communities, and one of our slogans is that HIV is not a moral issue, it's a health issue. And our religious leaders are saying that, and the church has been a place where stigma has been in for a long time, but when the religious leaders have stood up and said that, then people have come up and I think therefore using religious leaders is one of the ways of reducing stigma.
David, did you have anything you would like to add to that? Hello? Okay.
Sorry, I was on mute.
Hi.
Yeah. Nkatha said earlier that religious leaders in communities have a very influential role. They have this weekly captive audience, and the audience really pays attention to what the leaders say. So it's a really very important leverage opportunity that we need to take advantage of. And the more pastors we can get, and the more imams and sheikhs taking the lead there, the better off we're going to be.
Great. Thank you both so much. Next question is from Ashley Gibbs. Could you speak specifically about approaches to reducing stigma against key populations, including men who have sex with men, transgender persons, and injecting drug use? And David, if you want to start with that.
Sure. I think it's important. It's an important question because there really are two different types of stigma involved here. One is stigma from even associating with someone who has HIV, regardless of how they got it. And the other is someone whose lifestyle or behavior somehow seems outside the norm, a marginalized population. And so it's important to recognize that there are these two different dimensions of stigma. And frankly, the first one is easier to deal with than the second. So one recommendation is for faith communities to first solve the first one, which is more likely involved with stigma against members of their congregations. And then, as you've learned how to deal with stigma, that gives you a basis for reaching out to marginalized populations. And for reaching with marginalized populations, dialogue and interaction are far and away the best way to reduce stigma issues like this. In our church, I'm a Presbyterian. We had some national policies related to same-sex behavior, and in my particular congregation was very divided about that. You know, what do we do? And it turned out the ones who were more comfortable with the same-sex policies were the ones who had friends that they knew were gay. The other people had friends who were gay, but they probably didn't know it. And so that was that was just because of dialogue and friendship that it really solved the issue.
Nkatha, do you have anything you would like to add to that?
No, really. I think David has talked about the same things. Thank you.
Great. We have another question from Helen. This question is for Nkatha. Do you have interventions targeting young people living in informal settlements in Kenya?
Yes. Actually, what I was talking about, working with the Muslims, and that when we developed the sermon guides, we developed that in Nairobi's Korogosho slums. And what we did is, beyond taking the religious leaders, we also took youth leaders from the churches. So yes, we have programs in the slums, in the slums in Nairobi, and just to add on that, we therefore are looking at not just the young people, we're also looking at specifically boys and men in the slums, and looking and using the fact that the cultural, the African culture, for example, opportunities around initiation into adulthood, male circumcision programs, and using those as avenues of reaching the young men and boys in communities through the churches. Yeah, but we have programs in the slums.
Great. You kind of just answered this other one, but there was another question from Gloria, and maybe David wants to say it from his side if he has anything. With the Youth Bulge, how are the men and boys specifically engaged in HIV prevention services within faith communities?
Could you repeat that again? Sorry, Katie.
Yeah. Sorry. With the Youth Bulge, boys specifically engaged in HIV prevention services within faith communities.
The best thing that I've seen are the safe spaces, like Nkatha already mentioned, provide an opportunity for young people to talk with each other in a supportive environment, because it's a very complicated time of life, and to have places where they can talk about the issues that they face is a very powerful tool.
Thank you so much. Another question, and this could go to either one of you, I think. When working on HIV and AIDS, is that the only health issue that needs to be addressed, or are there points of integration with other health services? Nkatha, maybe you want to start?
There are many, and I was talking about issues to do with family planning, male circumcision. We have dealt with sexual and gender-based violence. So we really are looking at faith leaders or working with faith leaders in relation to all aspects of life. I mean, even in terms of nutrition, a wash, so any area that the audience would be the church. So it's not just to do with HIV and AIDS. However, some of these become priority because of what is happening currently.
There's also the effect that a separation of services can have on stigma. Ultimately, we want to get to a point where a person's HIV status is just a natural part of their health condition, and doctors deal with that as just another health condition. But when services are separated, then that has the effect of making people with HIV somehow feel different or worse or stigmatized or marginalized.
Great. Okay, a question from Ray Martin. Are churches, in your experience, are churches still using the old prevention terminology of ABC? Abstinence, be faithful, or use condoms? David, do you want to speak first?
Sure. And Nkatha knows this too, but it has become less emphasized, and I think the main reason is that there is so much of a focus on individual responsibility rather than social responsibility. They're saying it's all up to you, and that means that anybody who has HIV, it's their fault, regardless of whether it is their fault or it isn't their fault. So that has this very strong stigmatizing effect. And it also says, well, you know, if you're not good enough to abstain and you're not good enough to be faithful, well, then all right, use a condom. But man, you're really a jerk. It's that kind of attitude that the ABC model pushes on us. Inarella has come up with a different framework they call SAVE, which is, Nkatha, if you can get these right better than I can, go ahead. Safe behavior, access for all, voluntary counseling and testing, and empowerment, I think, are the SAVE. Nkatha, do I have that right?
Yes, you do. You do.
David?
No, that I'm sorry, I'm done with that.
Okay.
just the SAVE model is a little broader framework.
Great.
And so it avoids some of the issues of the personalization of ABC.
Nkatha, did you have anything you'd like to add to that? No, really, just to emphasize the fact that I think that the church is embracing a more is more open to discussing the issues of HIV prevention in a broader way than looking at it as it was traditionally. And when we teach, we are talking about HIV. We are no longer we talk to them and tell them that we are no longer thinking about how this happened. Here we are now. The person has HIV, so what next? So it's a less judgmental approach. And we haven't had any problems with the religious leaders we've worked with in terms of them actually taking that up. And yes, like you mentioned, the SAFE model, because in most of these places we've worked with in Inarella who have better, they have worked more with religious leaders, and so they've been very supportive in helping us know how to approach the religious leaders in terms of HIV and AIDS and issues that could be controversial in relationship between health and the theology. Yeah.
Great. We have one last question. It'll be pretty quick. Well, okay, another one. This one is from Grace. Is there any plans for training lay counselors in the church? And maybe to you, Nkatha.
This really depends on country to country, and if their country policies accept lay counselors lay counselors, that would be really the prerogative of whichever organization. But I can mention that in Kenya, we actually wanted to train religious leaders as HIV counseling and testing counselors. And we are still negotiating with the National AIDS Control Council, especially now that we have self-testing kits. So yes, it can be done, but obviously you have to work with your national, the Ministry of Health in different countries and what they accept and do not accept.
Great. And just because there was one last one, we'll go ahead and do this quick. This one is to David, and it is from Linda Bales Todd, and she would just like to hear a few of your thoughts on the backlash against family planning in the U.S. and how faith groups can help to counter this shift. Yeah, we have about 1 minute.
Yeah, to me, that's just a symptom of this reluctance to use scientific evidence, that we somehow think without talking about family planning, somehow the right-sized families will come out anyway. And so to me, it's just a symptom of the broader issue of not being able to focus on the science. And to me, the science gives us, it's what Gideon said about separating moral behavior and safe behavior. And family planning is going to be one of those things that's going to the side where scientific evidence tells us about how to deal with that behavior. I don't know if that was articulate enough.
Hopefully it was good. Well, thank you both for being here and for presenting and being willing to answer some of these questions. And thank you to everyone for joining us, everyone out there for joining us on today's webinar on HIV and AIDS and the role of people of faith. The webinar will be available on CCIH's YouTube page, and we encourage you to share the recording with colleagues who were unable to join and hope you continue to share your work on this issue. CCIH has a Google group on HIV and AIDS. To join, visit the CCIH website at www.ccih.org and scroll down to events and groups in the footer and select networking groups. Thanks again. Bye.